So what are the implications of deprescribing? Is there more to it than just crossing off a few medicines?
There are numerous barriers and enablers, things that will help practitioners and patients to proactively stop a medicine. And what we need to do is we need to design strategies that address these barriers and the enablers. The thing is, there's no one size fits all. So what interventions really need to do is fully understand what the barriers and enablers are for the specific context that they want to increase deprescribing, proactive deprescribing. So, for example, is it in primary care? Is it in secondary care? Is it with older people? Is it with people? So, for example, I'm working on implementing opioid deprescribing in one ICS. And so we have very different barriers and enablers to proactive deprescribing compared to another project I'm working on, where we're looking to increase proactive deprescribing in the hospital setting with older people. So what we need to do as a research community, the NHS as an organisation, is really look to understand for each of these different sort of contexts and patient populations, prescriber populations, what are the key barriers and enablers, and then design strategies to address those rather than a one size fits all. So we really do need to harness behavioural science to address proactive deprescribing.
I see. So where do pharmacists fit into all of this? Are they the people who should be doing the deprescribing?
In 2018, we surveyed 150 hospital inpatients and their family members. They said that they wanted the deprescribing discussion to be initiated by a doctor. When we spoke to hospital pharmacists, they also said that they would prefer that the discussion was initiated by the doctor, and that they were happy to identify medicines that might require stopping to work with the doctor, and then for the doctor to then initiate that discussion. In contrast, as I mentioned earlier, I'm working with primary care teams to support opioid deprescribing. And I know that in many cases, this is being led by pharmacists, and they are initiating the deprescribing discussions. So there is no one size fits all, and this goes back to really understanding who the population are, what the medicines are that are involved, who are the pharmacists that are doing this, and then designing strategies that work for that context.
And what about patients? Do we know anything about how they view deprescribing? Won't they just see it as another way of the NHS saving money?
So certainly prescribers have a misconception that patients are resistant or will be resistant to proactively having their medicine stopped. And that is a significant barrier to pharmacists, geriatricians, doctors across the board initiating deprescribing discussions. So we know that this is a misconception because when we surveyed 150 people, they actually said, we're horrified that you would keep us on medicines that might not be the right thing for us. So there is definitely an appetite for medicines to be stopped where the chance of harm outweighs benefit. Conversely, when we look at trials that have tried to increase proactive deprescribing, and deprescribing has been offered to a patient, in the majority of cases, they've been rejected by the patient. So there is that disconnect between patients saying, actually, we want to make sure that we're only on the right medicines, versus when they're asked, would they like to consider stopping, they opt not to. And we recently did an international survey of people so pharmacists, doctors, nurses, anybody with a role in deprescribing medicines, proactively deprescribing medicines. And what they said is that actually they feel one of the key challenges to proactive deprescribing is not having the time to have that meaningful discussion about this is the information that I have collected from you about what your goals and priorities are. This is the clinical information that we have about the balance and the benefits, presenting that all to the patient and then supporting them to make a decision. So they felt they don't have the time, and that also that in some cases don't have the skills to navigate that discussion. So that may shed some light on this disconnect between patients absolutely wanting to only be on medicines where the chance of benefit outweighs harm versus being resistant to medicines being stopped when it's proposed by a member of the healthcare team.